Tourette Syndrome, Diagnosis and Comprehensive Behavioral Intervention. Tourette Syndrome, TS, affects approximately 0.3 to 1% of school-aged children globally, with a male-to-female ratio of 3 to 1 to 4 to 1. The pathophysiology involves dysregulation of cortico-striato-thalamo-cortical (CSTC) circuits, particularly involving dopaminergic hyperactivity in the basal ganglia, supported by neuroimaging and genetic studies. Diagnosis is clinical, requiring multiple motor tics and at least one vocal tic persisting for more than 12 months, with onset before age 18, per DSM-5 criteria. First-line behavioral treatment is comprehensive behavioral intervention for tics, CBIT, while pharmacotherapy with alpha-2 adrenergic agonists, e.g., clonidine 0.1 to 0.4 mg/day, or antipsychotics, e.g., risperidone 0.5 to 6 mg/day, is reserved for moderate to severe cases. Key points. Note: Tourette syndrome, TS, has a global prevalence of 0.3 to 1% in children aged 5 to 17 years, with higher rates, up to 3%, in clinical samples. Diagnosis requires greater than or equal to 2 motor tics and greater than or equal to 1 vocal tic, present for greater than 12 months, with onset before age 18, per DSM-5 criteria. The male-to-female ratio in TS is 3 to 1 to 4 to 1, with peak tic severity occurring between ages 8 to 12 years. Up to 85% of individuals with TS have at least one comorbid psychiatric condition, most commonly ADHD, 50 to 60%, OCD, 30 to 50%, and anxiety disorders, 25 to 40%. First-line non-pharmacological treatment is comprehensive behavioral intervention for tics, CBIT, which demonstrates a 47% response rate, greater than or equal to 6-point reduction on the Yale Global Tic Severity Scale, YGTSS, in the 2010 NIH-funded CBIT trial, N equals 126. Clonidine is a first-line pharmacologic agent, initiated at 0.05 mg orally at bedtime, titrated weekly by 0.05 mg to a maximum of 0.4 mg per day in divided doses. Risperidone, a second-generation antipsychotic, is effective at doses of 0.5 to 6 mg/day orally, with a number needed to treat NNT of 4.0 for greater than or equal to 25% tic reduction based on a meta-analysis of 12 RCTs, JAMA Psychiatry, 2013. Up to 20% of TS patients develop self-injurious behaviors, particularly with complex tics involving headbanging or eye-poking. Deep brain stimulation, DBS, of the centromedian parafascicular complex, CMPF, of the thalamus or globus pallidus internus, GPI, is FDA approved under humanitarian device exemption for severe, treatment-refractory TS, with response rates of 35 to 50% in open-label trials. The YGTSS total tic score ranges from 0 to 50, with scores of 25 to 34 indicating moderate severity and greater than or equal to 35 indicating severe tics. Genetic studies show heritability of TS is 0.77, with over 400 risk loci identified in genome-wide association studies, GWAS, including SLITRK1, HDC, and CNTN6. The average age of tic onset is 6.0 years, SD plus or minus 2.0, with 75% of cases presenting by age 7 and 90% by age 11. Overview and epidemiology. Tourette syndrome, TS, is a chronic neurodevelopmental disorder characterized by multiple motor and at least one vocal tic, persisting for more than 12 months, with onset before age 18, as defined by the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5. The ICD-10 code for Tourette syndrome is F95.2. TS is part of a spectrum of tic disorders, which also includes provisional tic disorder, tics less than 12 months, and persistent, chronic, motor or vocal tic disorder. Globally, the prevalence of TS in children aged 5 to 17 years is estimated at 0.3 to 1%, based on population-based studies from the United States, Europe, and Asia. The Centers for Disease Control and Prevention, CDC, National Survey of Children's Health, 2016 to 2017, reported a prevalence of 0.3%, 95% CI, 0.25 to 0.35% among U.S. children, translating to approximately 140,000 affected individuals. In clinical referral populations, prevalence rises to 3%, reflecting ascertainment bias. Regional variations exist. Studies in South Korea report a prevalence of 0.7%, while data from the UK suggest 0.5%. Incidence rates are less well-defined but are estimated at 3.4 per 10,000 person-years in pediatric populations. Pathophysiology. The pathophysiology of Tourette syndrome centers on dysfunction within the cortico-striato-thalamo-cortical (CSTC) circuits, particularly involving the basal ganglia, thalamus, and prefrontal cortex. Neuroimaging, genetic, and post-mortem studies support a model of disinhibited motor output due to imbalanced excitatory and inhibitory neurotransmission, primarily involving dopamine, GABA, and glutamate. Dopaminergic hyperactivity is a core feature. Positron emission tomography, PET, studies using superscript 1c raclopride show 20 to 30% increased D2/D3 receptor binding in the striatum, caudate and putamen, in TS patients compared to controls. This correlates with tic severity, R equals 0.65, P less than 0.01. Post-mortem analyses reveal elevated dopamine levels in the substantia nigra and increased tyrosine hydroxylase activity, the rate-limiting enzyme in dopamine synthesis. The HDC gene, encoding histidine decarboxylase, is implicated, a rare nonsense mutation, P.arg255-TER, disrupts histamine-dopamine crosstalk, increasing striatal dopamine release in mouse models by 40%. Clinical presentation. The classic presentation of Tourette syndrome includes multiple motor tics and at least one vocal tic, with onset before age 18. Motor tics are present in 100% of cases, with simple motor tics, e.g., eye blinking, head jerking, occurring in 90% and complex motor tics, e.g., touching, copropraxia, in 60%. Vocal tics occur in 95% of patients, with simple vocal tics, e.g., throat clearing, grunting, in 85% and complex vocal tics, e.g., echolalia, coprolalia, in 15%. Coprolalia, the involuntary utterance of socially inappropriate words, is present in only 10 to 15% of TS patients and is often overemphasized in media. Tics are semi-voluntary and preceded by a premonitory urge in 80% of patients. This urge is described as an uncomfortable sensory sensation, e.g., tension, itch, relieved by performing the tic. Tics are suppressible for short periods, mean 30 to 60 minutes, after which rebound exacerbation occurs. They are exacerbated by stress, 70% of patients, fatigue, 60%, and excitement, 50%, and diminish during focused activities, e.g., reading, video games, in 40%. Diagnosis. Diagnosis of Tourette syndrome is clinical, based on DSM-5 criteria. The diagnostic algorithm begins with a detailed history and physical examination, focusing on tic characteristics, onset, course, and comorbidities. DSM-5 requires, laboratory testing is not routinely indicated but may be used to exclude secondary causes. Recommended tests include, key points, presence of greater than or equal to 2 motor tics, simple or complex, and greater than or equal to 1 vocal tic, simple or complex, although not necessarily concurrently. Tics occur many times a day, nearly every day or intermittently, for more than 12 months. Onset before age 18. Tics are not attributable to another medical condition, e.g., Huntington's disease, post-infectious encephalopathy, or substance use, e.g., cocaine, amphetamines. References. 1. Fry J., Tourette Syndrome and Tic Disorders. Continuum, Minneapolis, Minnesota. 2025, 31, 4/11/20-1151. PMID, 40748111, https://pubmed.ncbi.nlm.nih.gov/40748111. DOI 10.1212/cont.00000000000001595. 2. Nilisi et al. Tourette Syndrome and Other Tic Disorders of Childhood. Handbook of Clinical Neurology. 2023, 196:457-474. PMID 37620085. https://pubmed.ncbi.nlm.nih.gov/376200085. DOI 10.1016/B978-0-323-98817-9.00002-8. 3. Alraweda AA et al. Functional Tics and Tic-like Behaviors. Handbook of Clinical Neurology. 2026, 215:55-62. PMID 41633747. https://pubmed.ncbi.nlm.nih.gov/416333747. DOI 10.1016/B978-0-443-13554-5.00017-1. 4. Kohler K. et al. Description, implementation, and efficacy of the comprehensive behavioral intervention for tics as first-line treatment for Tourette and other tic disorders. Journal of Child and Adolescent Psychopharmacology. 2025, 35, 3126-134. PMID 39311713. https://pubmed.ncbi.nlm.nih.gov/393111713. DOI 10.1089/cap.2024.0023. 5. Rackham et al. Internet-based guided self-help comprehensive behavioral intervention for tics, CBIT, for youth with tic disorders, a feasibility and effectiveness study with 6-month follow-up. European Child and Adolescent Psychiatry. 2022, 31, 2275-287. PMID 33231786. https://pubmed.ncbi.nlm.nih.gov/332311786. DOI 10.1007/S00787-020-01686-2. 6. Morandbull US et al. Evaluation of EEG biomarkers of comprehensive behavioral intervention for tics in children with Tourette syndrome. Clinical Neurophysiology, Official Journal of the International Federation of Clinical Neurophysiology. 2022, 142:75-85. PMID 359870993. https://pubmed.ncbi.nlm.nih.gov/359870993. DOI 10.1016/j.clinf.2022.07.500. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.